My name is Suzanne Crocker. This is a diabetic foot exam for UAH Nursing 500. When you first approach your patient, you want to greet them and then ask about any recent history. You particularly want to know about their blood sugar control over the last few months, when their last A1C is, and ask about if they've had any foot cramps, foot pain, any unusual burning in their legs, any unusual symptoms. It's also important to do a good general review of systems and find out if anything unusual has gone on. For example, this particular patient is going to have very weak ankle reflexes because of a schwannoma tumor. Now, normally a weak ankle reflex might be a sign of advanced diabetic neuropathy, but in his case, it's related to a totally different disease process. Now, when you first examine your patient's feet, you want to look carefully at the skin. You're going to look at the top, the bottom, look all around, be sure there's no sores, no ulcers. You're inspecting between the toes to make sure there's no fungal infection that might be shown by excoriated areas. You want to check the temperature. Be sure that the top and the bottom of the feet are the same temperature. They're both warm, which would indicate good circulation. And you want to check the pulses, both the dorsalis pedis, which he has a good, strong pedal pulse, and also the posterior tibial pulses. And that's good and strong as well. One other way to check circulation in the foot is simply to press down at the top of the toe until it blanches. You release it, and it should refill to a nice pink color within 3 seconds, which his did. We'll do the other toe as well. Press down, it blanches, release, and the color comes almost immediately back. You can also see the pattern of hair growth. Having plenty of hair in the lower limbs and feet is also a good indicator that the circulation is doing pretty well. Now, when we begin to look at the skin of this patient, you'll notice that he has a few kind of rough areas around his heel, just kind of dry skin. It's not cracking yet. That would be called xerosis, and it would be important for this patient to use a good cream, maybe a lanolin-based cream, on his feet to keep them soft, because you don't want any cracks to develop. In a diabetic foot, a crack can lead to an infection. Infection can lead to an ulcer. You would also want to examine the toenails. And something I noticed right off the bat is that this patient does not cut their toenails very appropriately. And you can see where he's had to have surgery here recently for an ingrown toenail. So one of the important things to teach a diabetic patient is appropriate ways to care for their feet. How to cut the toenails at a straight angle, not cut them off too short or too long, and be sure they see a podiatrist if they have any corns or any problems. He has a good high arch. There's no Charcot deformity here. Also, the metatarsal heads are all nice and even. There's no prominent metatarsals. There's no bony deformities. The second toe is a little bit longer, so where it presses down on the shoe a little bit, there's a small callus there, and that would be an important area for this patient to watch so that it doesn't turn into a foot ulcer. Also, looking at his feet, you'll notice how red the small toe is. On both of them, you can see the redness and irritation in that small toe. That may be a sign that their shoes are too tight. I would definitely counsel this patient to go to the shoe store and have their feet remeasured to be sure they're wearing an appropriate shoe that is not too worn and that is wide enough for their feet to prevent any possible ulceration. Now, next I'm going to check my patient's strength. So, sir, could you press down towards me? Good. Now pull back towards you. Pull really hard. Good. He has excellent strength in both of his feet. And that's an important marker of muscle strength down here. I'm going to go ahead and check his reflex now. Get him to rest one ankle on the other and hold it up. And he has a slight reflex, but like I said, after the schwannoma tumor removal, the reflex has been a little diminished in both of his feet. Check the other side as well. And it's almost completely absent on that left side. The next thing that we're going to do is to use the monofilament to do the monofilament testing on the bottom of his foot. Now, sir, I'd like for you to close your eyes, please. And this won't hurt a bit. It's kind of like a little fishing line. And tell me where and when you feel the light touch. Do you feel it?
No.
Okay. How about here?
Yes, on my middle toe.
And here?
On my far left toe.
Okay. How about here? How about here? Do you feel anything here?
On my heel, left heel.
And how about here?
On the top left foot.
Okay. Now, in the interest of time, I'm not going to do both feet at the same time. Once more, this could possibly for him, since he's not actually a diabetic patient, be related to some sensory loss due to the schwannoma tumor removal. But the patient has lost sensation pretty much over the bottom of the hallux and the metatarsal head of that. If he were a diabetic patient, that would be very concerning, because if you can't feel the bottom of your foot, it's very easy to develop an area of ulceration and not even be aware of it. 75% of amputations in the first world countries are related to diabetic neuropathy. So it's a very, very serious condition that affects morbidity and patients. Now, the next thing we're going to test, which will be interesting to see if you can feel this, is the vibration reflex. Now, typically, neuropathy progresses in such a way that you lose the vibration, the sense of vibration, long before you lose the sense of light touch. So, let me see your wrist. I'm going to show you what this feels like. It's a vibration sense. Now, I want you to close your eyes and tell me if you feel this.
Yes.
And tell me when the vibration stops.
No.
Okay. We're going to try his other toe.
Yes.
And tell me when it stops.
No.
Okay. Very good. So he has really good vibratory sense in both feet, which is unusual for him to have that sense of vibration and lose the monofilament touch. Now, I want to do one more test to see if you feel sharp or dull. So this would be sharp, this would be dull. So close your eyes and tell me what you feel.
Sharp. Sharp. Dull. Dull.
Good. Okay, you can open your eyes now. Now, one thing that I want you to be very careful to do from now on is to check your feet every day. I'm going to send this little monofilament home with you, and it's very important for you to inspect your feet. If you can't bend over and pull your feet up enough to see the bottom of them, use a hand mirror to see the underneath. You need to be looking for any areas like these little calluses that are developing, because sometimes a callus can thicken, develop a blood blister under it, then sometimes that can open up and turn into a large ulcerated area very, very quickly. So it's important that you keep checking your feet. Now, this particular patient would probably need to be rechecked again in 6 months because of the slight loss of feeling on the big toe over here, just to be sure. If he were a diabetic patient, we would recheck him again every 2 to 3 months, actually, to be sure that he was not developing any ulcers. And we would definitely counsel him about his shoes, using wider shoes, shoes that fit his feet better, using a little bit of lotion on his feet, and cutting the nails more straight across instead of at an angle. And this concludes this diabetic foot exam.